Welcome to another episode of Answers for Families. I'm your host, Dr. Tommy Martin, who is a pediatrician in the Pediatric Intermediate Care Unit at Boston Children's Hospital. And today we're going to be talking everything about caring for patients with cleft lip and cleft palate. And today we have an expert in the field who I'm super excited to have, Dr. Carolyn Rogers-Visna. How are you doing?
I'm doing great. Thanks so much for having me.
Yes, of course. I'm super excited to dive into this. I know within my unit, I care for patients with cleft lip and cleft palate. And I know in the ICU, they care for a lot of patients with this as well. And so we have a lot of families that have a lot of questions about this. So
Absolutely.
Very important topic. Very good. So just to start off, I think it's important to know just the basics. What is cleft lip and cleft palate?
So a cleft effectively is a gap in tissue, and you can have clefts of lots of different body parts. But when we're talking about the face, most often we're talking about gaps in tissue of the nose, the lip, which includes not just the skin, but the muscle of the lip, the gums, including the bones and teeth, and then the roof of the mouth. So the hard palate, which is the bony part of the roof of your mouth, and then the soft palate, which is the muscular part that you use for speech. And so a cleft lip or a cleft palate could affect some combination of all of those different structures, and sometimes it affects all of them together.
Okay, and how, just in the general population, how common is this?
Yeah, we often think of cleft lip with or without cleft palate, and then cleft palate only as somewhat separate entities. And so, we know the incidence of clefting based on those. So a cleft palate only happens in about 1 in 1,500 live births, whereas a cleft lip with or without cleft palate is somewhere in the range of 1 in 700 to about 1 in 1,000 in the US. And the incidence varies a little bit depending on ethnodemographics, and so the incidence in the US is a little bit different than the incidence in Central America and other parts around the world.
Okay, yeah, I know that with those statistics, I think growing up I had maybe 2 or 3 classmates that had cleft lip or cleft palate. And so I think most children throughout their school years will probably meet a child that has this.
That's absolutely true. In fact, there are lots of famous people that I'm probably not allowed to mention, including Super Bowl winning quarterbacks
Wow.
who have clefts. And I think it's important to realize that clefts are treatable. That's not to minimize the impact that they have on children and their families, but you can live a very full life despite having been born with a cleft.
That's so important. I hope all children who hear that message take that to home and just keep it with them. And so, do we know why this happens? Like, is it considered a birth defect? Does it happen? When does it happen, or why does it happen?
Yeah, I don't love the term birth defect. I think in the cleft and craniofacial world, we would typically call it a facial difference because there are lots of different kinds of facial differences, and frankly, we're all a little bit different. But this is something that happens early on in development. So typically, a cleft lip starts around 5 or 6 weeks of gestation. So it happens before many people even know they're pregnant. And a cleft palate is more like 12 weeks of gestation. So it happens. It's a developmental phenomenon that happens very early. In most cases, we don't know exactly why they happen. They have some hereditary influences, some environmental influences, and a lot of random influences. I think as we learn more about genetics, we know more and more about the hereditary aspect, but that's not to say that it's something mother or father did wrong with a certain exposure. It's really the cumulative effect of a lot of different things, many of which are out of our control.
You said so many things that I think are so important, but quickly, I want to know, with the hereditary aspect, do we know what percentage, if mom and dad have it, that the children will have it?
Yeah, so it's about 4%. So if a parent or if another child in that family has it, your risk goes from being less than 1% for having a child with a cleft to about 4%. And when you add family members, it gets higher and higher. So there's definitely some genes we know of that influence it, but they're not single hit types of things where if you have this gene, you'll definitely have a child with a cleft. They just increase your risk for it.
Okay, yeah. And the things that I love that you said, I just have to touch on the term facial differences. I think that is such important and such great terminology outside of birth defects. So thank you for bringing that to our attention. I have a child with developmental disabilities, or he has a rare condition, and we use different terminology that I think highlights just great importance in their differences and how all differences are so beautiful and wonderful.
Absolutely.
So thank you for that. And then also that it is nothing that mom and dad did, that there was nothing that you guys did that caused this. And I think that is so important. I know that parents, if they have a child with differences, they can have a lot of guilt with that. So thank you for sharing that as well. So with the journey of having a child with cleft lip or cleft palate or a combination of the two, could you kind of walk us through their journey from maybe if it could be detected during pregnancy all the way through their journey?
Absolutely. Excuse me. So I'll talk as if a child is being born with all of the above, just
Okay.
to illustrate, everything that could happen. But I think one of the key things to know is that every cleft is different, and not every child who has a cleft is going to need all of the different treatments that we'll talk about. So typically we learn about a cleft lip on the anatomy scan that women have around 18 to 22-ish weeks. Sometimes we're seeing families as young as 16 or 17 weeks now, simply because imaging has gotten so much better. We learn more early. But a cleft palate's not usually visible, and so if somebody has a cleft palate without a cleft lip, often it's a surprise diagnosis at birth. When there's something that we suspect here at Children's, we usually will get a fetal MRI, primarily so that we understand the extent of clefting and can know what a child needs at birth. When there's a cleft lip only, usually birth plans can be exactly as a woman was planning, and so you could deliver at any local hospital. There are not usually any special needs, but when there's a cleft palate, it often means some feeding challenges early and changing the plan to breastfeed if somebody had planned on that. And that's often, I think, a hard conversation to have with women. There's so much pressure to breastfeed these days. I know that as a mom myself, it doesn't always work out no matter what you do, but generally with a cleft palate, it's not possible to generate suction. And so we like to do some education before birth on how to use specialty bottles that allow a baby to get milk without having to generate suction. And then you can absolutely pump and feed breast milk through a specialty bottle, and a lot of women will do some nursing for comfort and bonding after nutritive feeding with a bottle. So once we know about a diagnosis of cleft, we usually like to meet a baby in the first couple of weeks of life to implement various treatments, do a feeding assessment, and know exactly what the extent of clefting is. And then from there, develop a treatment plan that's based on that child's specific anatomy and their family situation. We see families from down the street in Boston. We see families from other countries, and which treatments you choose and the timing depends a little bit on all of the above. You can't expect a family coming from another country to come in every week for different treatments.
Right. Yeah, it'd be nearly impossible. Yeah, that's so much good information. And so cleft lip versus cleft palate. Cleft palate you may not see on the initial
Correct.
pregnancy scan, so in utero, but cleft lip you could see as early as you said 17, 18
Usually,
weeks?
yep.
Okay, great. And then throughout that time period, you guys will be following the mother during pregnancy?
Most of the time, there aren't any other anomalies
Okay.
that would warrant any kind of follow-up. Once we know that there's a cleft, we do some education, and in most cases, people proceed with a very healthy pregnancy. Having a baby with a cleft doesn't change your ability to have a typical delivery or whatever you were planning. And so, every now and then we see a cleft in conjunction with other things like heart defects, renal issues, brain issues, and those kinds of things can certainly change how a baby is cared for after birth, but a cleft only doesn't usually change anything that we do.
Okay, and then after delivery, you spoke briefly about feeding, which I think is so important. And what about any surgical procedures? I know that you said not everybody would need them, but how do you decide who needs a surgical procedure, who doesn't need a surgical procedure?
Well, it's not actually the surgical procedures, it's more the other adjunct things.
Okay.
So for a cleft lip, for example, when a baby has a unilateral cleft, meaning a one-sided cleft, there can be differences in the shape of the nose and in the width of the cleft, and so we may use pre-surgical devices to change the shape of the nose, change the size of the cleft, and those are typically implemented somewhere in the first few months of life. For example, we use a product quite often called the Dynacleft nasal elevator, which lifts the cartilage and helps to shape it and can round out a lot of the flattening that a child is born with, because infant cartilage is super moldable. We mold it for ear molding, we mold noses and clefts, but it's something that we have to start early on. And then we often involve our orthodontists in the first couple of months of life to do some work to bring the parts of the gums closer together and make the cleft easier to repair. So it's not so much that the surgical treatments are optional, but the other things we do to get the best surgical outcome are.
Okay, fantastic. And if surgery is needed, when does that happen?
Yeah, for an otherwise healthy child with a cleft lip, usually around 4 months. It
Okay.
may be give or take a month depending on, size at birth, gestational age, other things going on. But that's a pretty typical age for a cleft lip. And then for a cleft palate, typically around 10 months, and that may flex a little bit more depending on the needs of the child. Certainly having a cleft palate only can go along with other airway issues and things that may make cleft care not the most important thing in the child's care at the time. And so we usually wait until we know that we're going to be able to do it as safely as we can.
Okay, great. And then in terms of that first year of life, after that period, from ages maybe 1 to 4, are there any additional special hearing tests, screening tests, anything that needs to be looked into?
Yeah, even in the first year of life, those things matter a lot. So one of the things not everybody knows about a cleft palate is it can affect hearing because the muscles that you use for speech also function on your eustachian tube. So if you think about flying in an airplane and you can pop your
Oh,
ears
right.
when you yawn, you can't do that when you have a cleft palate. And so most children will have normal hearing at birth, but over time fluid will start to build up behind the eardrums. And so one of the cool things we're doing at Children's, our audiologists have a pilot program that's piloting early hearing aids for babies who have
Oh, wow.
moderate to severe hearing loss. Typically we'll have ear tubes placed at the time of the cleft palate repair, which treats that hearing loss. But we know more and more about how early speech and language development is so important to having good long-term speech. And so our audiologists have this cool loaner program. And so those things more and more are part of the things we do in the first year of life. And then beyond surgery, hearing follow-up, typically every 6 months to a year is really important. And then integrating speech therapy around 14 months of age, having regular speech follow-up, regular dental check-ins is important. Another thing, just to know is that when you have a cleft lip, oftentimes the teeth in the area of the cleft are affected, and it can mean missing teeth, it can mean extra teeth, and it can mean teeth that look normal but have reduced enamel and are prone to having cavities. And so it's really a multidisciplinary approach. It's not just surgeons, even though we tend to, drive everything in the first year of life. But really audiologists, speech therapists, and our orthodontics, they're really the people who are most important a little later on.
Wow, that's incredible. Because I've cared for patients with cleft lip and cleft palate, but I don't think I appreciated just how many people are involved in the care every day to make sure they receive the best care that they need. But that's incredible that you guys have such a great team.
Yeah.
And do these teams, for these families, do these teams ever meet together, or what does that look like when a patient comes to see you guys?
Yeah, typically because the surgical care is sort of the impetus or the emphasis of the first year of life, a lot of the care goes through the surgeon's office.
Okay.
But starting around 2 years of age, for most children, we'll see them as a team every year. Sometimes certain kinds of clefts may not require as much follow-up, but as a general rule, until kids are speaking well and until we have a good orthodontic plan, they'll see a speech therapist, a plastic surgeon, or an oral surgeon, and an orthodontist as part of the cleft program on an annual basis. And then we kind of change the focus as a team as different things happen. So the first 4 to 8 years is really all about speech and hearing. Orthodontists start to really play a bigger role as you get to 6, 7, 8, and the permanent teeth are coming in. But nobody ever really phases out completely. We are all involved and working together. We just, different specialties take the lead at different times.
Okay, great. And then, so for this whole process, when would you say they graduate from being seen by you guys, or are they a patient forever, or?
That's such an important question. I think, particularly for families who are new to talking about clefting, it seems like it's all done in the first couple of years. And cleft care is a long-term relationship, which is why I think it is so important to find a team that you feel good about, who you're going to want to get to know over a period of many years. We never really say anyone's totally graduated, but I would say that, for a child with a cleft palate only, we start to space out visits, when they're 8 to 12 years, but would like to follow them until they're at skeletal maturity, which for a girl could be 15, 16, for a boy might be 18, 19 years of age. And for someone with a cleft lip, there are often treatments like work on the jaws, orthodontic work, things to help nasal breathing that you do at skeletal maturity. And so we often follow young adults really into their late 20s, depending on what their needs are.
That's incredible. We've talked quite a bit about speech and how speech language pathologist, and speech therapy is huge in this population. What is, I guess, the development of speech, or how much does cleft lip and palate affect it? And then what does that progression look like throughout as they age?
So a cleft palate really primarily affects speech, and so we really think about the goal of cleft palate care as being to try to normalize speech.
Okay.
But some children who have cleft surgery still will need more therapy or an operation later in life. And so we typically start getting a good sense of speech around 4 years of age, just based on development. But we really follow kids until 6 to 8 pretty closely,
Okay.
because that's when they're starting to have, more adult-like speech patterns. Cleft lip doesn't exactly affect speech in the way you think of speech production. So, cleft palate will limit your ability to make pressure sounds, whereas a cleft lip does not. But particularly when kids are developing their permanent teeth, because they're in different positions, it can impact articulation, and you can have articulation distortions that are not necessarily treatable by speech therapy, but improve as the teeth are corrected with orthodontics and orthognathic care.
Okay. And so are there procedures or things that would help with speech development in that 7 to 8 age group, or what does that look like to try to improve speech?
Depends on the problem. So
Okay.
for people who have hypernasal speech, so it sounds like there's too much air coming out of their nose, there are a variety of operations we call that are VPI surgeries, or velopharyngeal insufficiency, that are geared towards reducing airflow out of the nose. And so typically the way working up for that surgery looks like is a speech therapist will evaluate them. If they think there's a concern for VPI, we have a second multidisciplinary clinic with an speech therapist, a plastic surgeon, and an otolaryngologist. It's our voice and resonance clinic. And the otolaryngologists perform a procedure where they put a little camera down the child's nose while a speech therapist is leading them through special tasks. And so we can see how the speech apparatus moves from the inside and make decisions about whether more speech therapy is needed, whether it's something that requires more surgery. And if it requires more surgery, what's the best kind of surgery?
Wow, it is truly incredible how much goes into this, and just how big the team is. I think I should have done a rotation in medical school to see all this happen, to see it firsthand. That's incredible. So as these children are aging and they have these annual visits, I know you talked about all the multidisciplinary teams, but could you just give us maybe a bird's eye view of what an annual clinic visit would look like with you guys?
Yeah, so a typical clinic visit, somebody would come in, usually spend 2 or 3 hours with us, meeting with a speech therapist, meeting with a surgeon, meeting with an orthodontist, and then we also have different specialties that get involved as needed, such as social work for psychosocial and family support. We have complex care pediatrician who works with us to help navigate other medical needs. And so they're long visits, but it gives us the ability to put all of our heads together and come up with a plan that is really patient-centered and really takes into consideration all of the specialties, because it's so easy in your own clinic to be siloed and just think, I'm a plastic surgeon. This is what I think is important, but it's nice to be able to put everything together. So they're longer visits, but it gives us the ability to really make good plans for the next steps. And I believe that families appreciate being able to see everyone together and know that we're all on the same page and not doing things that negatively affects the care that's being provided elsewhere.
Yeah, no, I think that's incredible. We have patients that come from all over the country, right? And so to be able to see everybody in one visit, even if it is 3 hours long, which is a crazy long visit, but to see all of their doctors in that one visit, and I think to see how much the team cares about them, how much the team is putting all their minds together to provide the best care. I think that's just so rewarding for the family. And I think it shows that you guys are doing incredible, incredible work. That's awesome. Next, I want to know, how does Boston Children's stand out in the caring for patients with cleft lip and palate?
We have one of the oldest and largest clinics in the country, and I would be remiss to not mention Dr. John Mulliken, who really kind of grew the clinic to what it is now. We see families from all over the world, and so we have a lot of experience dealing with different cultures, navigating the challenges of caring for children in far-off places, as far off as the Middle East and abroad, or even in Maine. We have a wonderful collaboration with the Maine Cleft program, where one of our surgeons goes there on a monthly basis and have a great back and forth there. And so I think those relationships do make us stand out. And I can also say one of the really nice things about having a history of surgeons who come and stay and orthodontists who come and stay. Steve Schusterman and Rich Bruin were two of our orthodontists who are here for 3-4 decades, like gives us the ability to have seen patients through 30 plus years of care and really understand the longevity. I mean, I've probably said this before, but cleft care is not one and done. It's really, childhood long care and even sometimes into adulthood, depending on the needs of the individual. And so those are things that we have experience with because we've had such great people who have come before me and really established that precedence. I also think we are doing a better and better job of trying to understand the patient perspective. This is a focus not just at Boston Children's, but of cleft care really around the country and around the world, integrating these standardized questionnaires called patient-reported outcome metrics into clinic visits. We use them to really understand how kids and young adults are doing, not just from aesthetic or dental perspective, but psychosocially and in their whole life. And I think it's been eye-opening to see how things sometimes change or how kids are doing better or worse than what we thought. And it's still, as it is in every specialty, hard to navigate psychosocial challenges, but without asking the questions, you don't even have the ability to know where to start. And so I think we're doing a better and better job of asking those questions, and that's going to lead us to being able to provide more services that are important, particularly for adolescents and young adults who are navigating teenage years, which are already so hard. And when you have a facial difference, it just compounds that.
Yeah, I think anytime we have the opportunity to get a glimpse into the lives of our patients and truly what they're feeling and experiencing, it's extremely eye-opening to us and can shape patient care drastically for the better. So I think it's incredible that you guys are doing that questionnaire and seeing into their lives. And I also believe that you guys have an extremely high patient volume of patients with cleft lip and palate. Is that correct?
We see about 900 patients a year.
Goodness.
That's not to say it's 900 new patients,
Yeah.
but our clinic, between follow-ups and new patients, sees about 900 a year.
Wow, that's incredible. So we are gonna have to end here shortly, but I just wanted to ask you one last question. That would be if you had anything to say to parents with children with a cleft lip or cleft palate, what is something you'd want to tell them?
I think I would want to say connect with other families because it is really hard as a parent, especially sometimes as a mother, to get a diagnosis that you're not expecting. But I think there's nothing that's more valuable than the parent perspective. And when you see kids who are growing into adulthood and thriving, that's really inspiring and I hope very comforting. Nothing is more valuable than getting the perspective of other parents.
Incredible. I love that so much. Well, Dr. Carolyn Rogers-Visna, thank you so much for joining the webinar. And to all of our listeners, thank you so much for tuning in to the webinar. And if you want to stay closer connected, make sure to check out all of our social media channels. And if you want to learn more about cleft lip and cleft palate, check out the Parent Cast on our YouTube channel where you could check out the episode there.